Hello everyone, I'm Dr. Shivani Chandan, consultant obstetrician and gynecologist at Aster RV Hospital, Bangalore. Today I'll be talking about one of the most common medical disorders that we come across in pregnancy, which is hypertension. Now, what do we mean by the term hypertension? It means high blood pressure. Blood pressure means the pressure with which the blood is flowing in our body. So when the blood pressure becomes high, that is when we use the term hypertension. When we talk about pregnancy, there are different types of, or we classify hypertension into three broad categories in pregnancy. The first being chronic hypertension, which means that you've had hypertension before conceiving itself, or you have developed hypertension in the first half of the pregnancy, that is before 20 weeks. Then we use the term chronic hypertension. The other is pregnancy-induced hypertension, which includes gestational hypertension and preeclampsia. When we look at preeclampsia, that is something we do not look forward to actually. In preeclampsia, you develop hypertension after 20 weeks, and along with high blood pressure, you also develop some amount of protein that is leaking in your urine. When we talk about gestational hypertension, it is high blood pressure after 20 weeks, but without the protein leaking in your urine. Now, when I say blood pressure, there is a number that we use, right? You would have heard us saying 120 by 80 or 130 by 90. So there are two numbers that we use. So any value that is less than 140 by 90 is normal. When you reach 140, 90 and above, that is when we call it as hypertension. And at 140, 90, you do not really need any treatment, but you just need regular monitoring. Now let us look at hypertension in the pre-pregnancy phase. Right? So if you're someone who's already having hypertension, before you conceive, I would recommend that you come for a pre-pregnancy counseling. And during that counseling, I would definitely recommend checking the medications that you're on, whether they are safe to be taken when you're planning a pregnancy or whether they need to be changed. If they are not safe, we change them to safer medications and optimize your blood pressure before you conceive. If you have associated medical conditions that are, adding to the hypertension, then those also have to be checked and corrected before you conceive. Suppose you're someone who does not have hypertension, I would still evaluate you for certain risk factors. One being age. The elderly are at a higher risk of developing preeclampsia or hypertension in pregnancy. The second would be your family history. If you have parents, either your mother or father having hypertension, then you're at a slightly higher risk, and I will make a note of that so that we can do certain tests to predict if you will develop hypertension or not. The third would be, supposing you've had hypertension in your previous pregnancy, then you are at a 25% to 50% higher risk of developing hypertension even in this pregnancy. Then I will make a note to use some preventive aspects after you conceive. So this is about the pre-pregnancy part of hypertension. Suppose you have conceived and the first 3 months you have chronic hypertension, we keep a target of 140/90, not too low. At the same time, we see that your blood pressure doesn't cross 140/90. Supposing you've developed preeclampsia. Since I'm talking about hypertension, why are we so concerned about this hypertension? What is wrong if the blood pressure goes high? If the blood pressure goes high, it has implications both on the mother and the baby. Let's talk about the mother first. What are the implications on the mother? If the BP rises, it can cause end organ damage, it can cause acute kidney injury, it can affect the liver. So once we diagnose you with hypertension, we will do certain blood tests on a regular basis to see if the parameters are getting abnormal so that we get it back under control. Again, if the BPs go up, you're also prone for certain complications in pregnancy. The first and the most important would be eclampsia. Eclampsia is a condition wherein, because of the high blood pressures, the pregnant woman tends to throw a convulsion or a fit, which can be very difficult to manage in a primary health center or a smaller hospital. You definitely need an ICU setup. I'm mentioning this here to highlight that if you're hypertensive, you should always consult in a multi-specialty hospital where we have other disciplines like an ICU setup, like an intensivist who will help us manage complications. The other complications could be that it may affect your kidneys and your liver and your platelet count. So if the platelets fall, it can again cause bleeding issues during delivery. If your kidneys are affected, then we have to deliver you early. One of the most common indications for preterm labor is hypertension, because the final treatment is delivery. Once we deliver, preeclampsia comes under control. That is why it is important to diagnose it and manage it well during pregnancy. Hypertension does not necessarily present with symptoms. So even without symptoms, you will have hypertension. But if the BP goes very high and it's not diagnosed, you can sometimes end up with intracranial bleeds, you can end up with stroke, and that is the reason that regular checkup, coming for a regular checkup is important, because during every antenatal checkup, we make sure that your BP is checked. Now, coming to the implications on the baby. Now, what does hypertension do to the baby? First of all, the blood flow to the baby can sometimes get affected, resulting in growth restriction, less fluid around the baby. It can also cause abruption. Abruption of the placenta means the placenta getting separated from its bed because of the high blood pressures, right? And the end point is, if left untreated, it can even lead to intrauterine fetal demise, that is death of the baby in utero. That is why it has to be monitored and treated correctly. Now, coming to, I said, you can predict hypertension. So what are the predictors in early pregnancy? First is identifying the risk factors. Sometimes if you're elderly, if you're obese, if you're carrying twins, then if you've had hypertension in your previous pregnancy, these are all risk factors. So, I put an alarm saying I have to monitor you carefully. Then there are certain tests that we do along with your nuchal translucency scan. That is, around 12 weeks, we check the blood flow to the uterus. If there is a notch, or we look at an index called PI. Based on that, we make a note that you are at a high risk. So we can start this tablet called aspirin around 150 milligrams, so that the risk comes down. We can start you on higher dose of calcium. So coming to the predictors again, one is the blood flow, the risk factors. Another, we have a good blood test. One is that is PAPI and placental growth factor. These are blood tests that we can do, so that they give us a risk, whether you're at high risk of developing hypertension, lower risks. So that way we can start preventive measures, that is aspirin, calcium, making sure you go for a walk regularly, reducing salt in your diet, and at every visit checking your blood pressure. Now, supposing we've crossed this phase and you've developed hypertension, what next? First, we will do a blood test to see how the profile is. How is your liver functioning? How are the platelets? And how is the creatinine? That's the kidney. We do a baseline set of tests. We start you on antihypertensive, that is tablets to control the blood pressure. There are very few tablets that we prefer using in pregnancy. So we start those medications first at a low dose. We would request you, initially for an admission, so that we can do a 24 hours or 24 hours monitoring of the blood pressure, or even if you can do it at home in case of mild hypertension. So once your hypertension BP is under control, we will do regular screening for the baby's growth and for your blood pressure. If the BPs are fine, the aim is to continue the pregnancy till 37 weeks, which is when the baby is mature. But in case of severe hypertension, which is non-responsive to medications, or the BPs are not getting under control, or the baby's growth is affected, we may need to do a preterm delivery. In such cases, we prefer giving steroids beforehand for accelerating the baby's lung maturity. And we prefer giving something called magnesium sulfate, which helps, which is neuroprotective for the baby. And also in severe hypertension, magnesium sulfate is known to protect the mother from having a seizure. So we prefer giving that and then planning delivery. Suppose you've gone up to 37 weeks and there's been no issue. I think the most common question that I get from patients is, doctor, is it going to be a cesarean section? So let me guarantee you that hypertension per se is not an indication for me to do a cesarean delivery. We can induce normal labor, but we may keep a lower threshold for, we may not be able to wait for too long like in any other normal patient. And we will monitor your blood parameters. And in case they are getting deranged or your BPs are not coming under control, we may need to resort to a cesarean, but we can still try for a normal delivery. But if it's very preterm, like, you're 30 weeks and your BPs are not coming under control and your platelets are going low, your liver function tests are abnormal, we will need to deliver you early through a cesarean section. So the treatment for preeclampsia or pregnancy-induced hypertension is delivery. Okay, and those who have had chronic hypertension may develop proteinuria, that is leaking of protein, in the second half of pregnancy, which is when we call it as chronic hypertension superimposed with preeclampsia. And even in such cases, we are very, very cautious, and we prefer taking care of you at Aster because we have the support of all the other departments, the anesthetist, the ICU, the intensivist, the nephrologist, everyone is there. And if you suddenly end up with a seizure, then ICU is definitely a must. So what happens post-delivery? Most mothers are worried, doctor, why did I develop hypertension? Is it going to come down? So if you're someone who has chronic hypertension, the hypertension continues and you continue to monitor like how it was in the pre-pregnancy period. If you've developed preeclampsia, then most often the BPs do come down following delivery. For some people, it may immediately come down. For some people, it may take 2 to 6 weeks. So what is important is to continue monitoring the BPs till they come back to normal. So we do reduce the dose, but we keep you on monitoring for at least 6 weeks. And once the BPs have come back to normal, 6 to 12 weeks, and then we stop the antihypertensives. So if you ask me, are you at a higher risk of developing hypertension in the future? Yes. If you've had preeclampsia, you may develop hypertension in the future. So you need to make lifestyle changes like going for a regular walk, consuming less salt, eating healthy, and living a healthy lifestyle. Finally, I think the most important thing that I want to highlight in hypertension is that it's one of the most common medical conditions which is treatable, and preventable, and you can avoid complications if you come to a multidisciplinary team with, we are all specialized in high-risk pregnancy. So if you come to our team, we know how to handle it so we can avoid complications. And the end point is the importance of delivering in a multi-speciality because all complications can be managed, such as eclampsia, stroke. We have a neurosurgeon, we have ICU. So it is very, very important for patients who have hypertension in pregnancy to make sure you have your pregnancy checkups on time at a multi-speciality hospital with the complete team of physicians, gynecologists, intensivists, everyone necessary to handle your complications. For more information and for more details regarding hypertension, and if you're someone with hypertension, make sure you visit us to clear all your doubts and to make sure you're in safe hands.